on to our penultimate session. It's a very interesting debate. Both of our chairperson couldn't join due to some unavoidable circumstances. So I'll take the privilege to introduce our debater. The topic is SABR is superior to other local ablative technique in medically inoperable hepatocellular cancer. And we'll start with Dr. Ganesh Radhakrishna, who will be speaking for the motion. So Dr. Radhakrishna is a senior consultant clinical oncologist working in the Christie NHS Foundation Trust, Manchester. His main area of interest in GI cancer, including hepatopancreaticobiliary cancer and precision radiotherapy. He is a member of RCR Professional Standard Subcommittee and RCR Equivalence Committee, tutor of postgraduate clinical education course at University of Leeds. Over to you, Dr. Radhakrishna.
Good afternoon, everyone, and thank you, Animesh, very much for inviting me to speak today and all the organizers. I'm going to try and share my screen if that's okay, to see if it works.
So please go ahead.
Thank you. Are you seeing my slide deck?
Right, sir.
Yeah, you got it? Brilliant.
Yes,
thank you. So once again, thank you very much for the invite, Animesh and the organizers. Good afternoon. I hope everyone is okay. It's a long morning, but it's been a fantastic session. So congratulations to all of you. I've really learned loads. As the Congress actually highlights, it's about controversies. And so the first controversy is I've changed the title, as you will see. So I'm going to try and persuade you that actually binary discussions about superiority may not be the best argument for modern precision oncology. So I've changed it to SABR may be superior in medically operable HCCs in certain circumstances. So let's declare the issue that we're dealing with. There is no level 1 evidence to demonstrate superiority, quite frankly, of any ablative technique or one over the other. However, absence of evidence is not evidence of absence, and I think that's an important starting point, because we are very much at the inception and very much, I think, at the infancy of using non-surgical ablative techniques. I hope there are no surgeons out there in the audience, because I think, ultimately we want to render surgery as very much the final option and reserve it as the option of least preference. So very quickly, I'm going to give an overview about SABR and the evidence base in HCC, introduce the concept of combination therapies, because I think this is where we'll be going in the future. And we've already heard a fantastic array of speakers talking about the combination of systemic therapy, particularly immunotherapy. And I'm going to try and introduce a little bit of that here and highlight the research and innovations in progress within the radiation sphere. So this is the UK Consortium guidelines. I think it's a very good start in terms of describing what I'll be talking about today. So stereotactic ablative body radiotherapy is precise irradiation, and that's quite important because we'll be talking about high-end image guidance and also using a high dose per fraction, and that does matter. Dose matters. It is our scalpel in radiotherapy. So most of you will be familiar with this diagram looking at the use of the Barcelona Clinic liver classification and the treatment strategies available. And as you can see here, ablation falls within the area of very early stage, particularly for patients who may not be suitable for resection, but also patients who may not be suitable for transplant. And so we kind of are in this early stage, early Charles Pugh criteria for HCCs. And I think in time we may start to encroach, and I think about this about all ablative techniques rather than specifically SABR, encroach into the intermediate stage as well. But that is an area of further research. So I think we need to start looking at this in a more precise and personalized way. And I think some of my colleagues who were in the discussion for the rectal cancer seminar earlier suggested that we need to look at individualization. And in the UK, we're very much into the term personalization because one size does not fit all. You know, every patient is different. They have a different molecular profile. We've heard all of that already. But also, I think that increasingly we're beginning to understand, particularly from our colleagues in the Far East, that patients who have viral-driven background cirrhosis may respond better to radiation therapies. And I also think we should avoid comparing apple with pears. And one of the things that Jonathan highlighted in the pancreatic session is, the comparison with ASPAC-5, where we were comparing systemic therapy with a local treatment, chemoradiation. And I don't think it's any surprise that actually chemoradiation was still better than surgery alone, but fundamentally was inferior when you're treating a systemic disease like pancreatic cancer. And so to start, let's start with data. And this is a very interesting paper that was published in JCO, comparing RFA to SABR. And it fundamentally suggested that RFA was superior. But let's be clear, we are comparing patients who initially were treated about 20 years ago. And you can see here already in this column here that many actually didn't even have a SABR at that point. And I think this is where we need to understand that SABR, like RFA, like TACE, like surgery, is a craft specialty. And so there is a learning curve. And this was very much at its infancy when it was starting. I think the other thing to sort of look at is the other factors that we know affect outcome. We know that tumors that are smaller in size will respond better to RFA than SABR. That may change as we are able to optimize the dose. But at the moment, if you have a peripheral lesion which is quite small, you would probably go for a thermal ablative technique. Certainly we would in our center. Most patients had suboptimal doses of SABR, and there was really no multivariate analysis looking at particular areas like the Charles-Pugh score and PVTT. And that's important because particularly at the early phases of introducing SABR and all the early studies, we took the ugly HCCs because we were starting to introduce this treatment in patients who had been heavily pre-treated, and that's certainly the experience in the UK as well. But this is 10 to 20-year-old data, and it's comparing apples with pears. That is not to suggest one's treatment is superior to the other. It's just that we don't know what may work for a specific patient. And this is a very nice little review article which sort of highlights where SABR or radiation treatment, which I'll be talking about in more detail, may fit. These may be patients who have a peripheral tumor which may be too large to get a good burn, patients with more comorbid and poorer outcomes, those with PVTT, particularly patients who in this group who may respond to other forms of radiation therapy, still looking at SABR, I'll come to that in a minute, and also if there is difficult access. I also want to introduce the concept that, patients aren't, it's not one size fits all, but it's also not one treatment for everyone. Actually, the combination of these treatments may actually be much better than just looking at unilateral decisions or single modality treatments. And this is quite interesting because this is two cohorts. So these are European cohorts of patients who were treated with TACE and SABR. And you can see the patients who had combination therapy in the dark line did better across all the outcomes. And this is in the Far East population. Once again, you can see patients who had and TACE or TAE did better than just single modality TACE. And this may be because in certain instances, patients who are receiving TACE or TAE may not necessarily have got an adequate or may have got a suboptimal treatment with it. This is so HCC SABR is now commissioned by NHS England. We use it routinely for a very strict criteria that is defined by NHS England. And this was on the basis of our commissioning through evaluation program, but also on the basis of this meta-analysis, which looked at 109 over close to 2,000 patients, which demonstrated a high local regional control rate and overall survival. And for patients with much larger tumors that would usually be associated with thermal ablation. And so we still have a reasonable control rate. On the basis of that, we were approved, and that's what we're doing now in the UK. But I also want to highlight data which is more concurrent with the current era. It's more relevant. So this is data that in the main is looking at the 2020s, but we have one outlier here, a couple of outliers here further down the line. The main thing to highlight with that is this is where I'd like to highlight the learning curve. So SABR, we know that the liver is very radiosensitive, and if you don't get it right, you will cause damage. And you can see that the rates of RILD and grade 3 toxicity were particularly high. But as time goes on, you can see that that is starting to diminish. And that's good, because obviously we're improving our techniques, we're understanding our craft, but also I also want to highlight the inclusion criteria here, that some of these patients had more advanced BCLC grades of their disease as well. But what we can see, but particularly with this group, is we are looking at very high local control rates and survival rates with SABR or SBRT. And what about the current treatment options and research in external beam radiation? So one of our colleagues, Jonathan Wadsley, highlighted the option of MR guidance. This is an example of the improved imaging that one can get with MR-guided adaptive radiotherapy. MR-guided adaptive radiotherapy involves real-time planning. So we plan on the fly whilst the patient's on the couch, and that might optimize the radiation dose and ensure we're getting a good biologically equivalent dose for treatment. This is not probably the best example of a cone beam CT. I think they've particularly selected a poor cone beam CT. We don't see so much graininess and loss of and so much artifact on our conventional current modern linear accelerators. But I think it just does highlight the difference that we can get with image guidance. And that difference is important because if we're more confident we're hitting the target, we can start to reduce volumes and escalate the dose. And we're using this for pancreatic cancer currently at the Christie. And as image guidance improves, the next thing is that, we are also able to optimize treatment based on functional imaging and embedding functional imaging into our planning system. And that will be also useful because potentially that may reduce our risk of radiation-induced liver damage or other comorbidities. And so this is a study that we are now embarking upon, trying to look at using functional imaging. And at the moment, we're very much at the planning stage of it, but we hope to integrate this into our planning for HCC patients moving forward. And we use multimodality imaging as standard. So we use MR and CT for our radiotherapy planning, and hopefully be onboarding these patients onto our MR-Linac very soon. And the other new kid on the block is proton beam therapy. Proton beam enables us to, as you can see here, the proton beam enables us to spare a substantial amount of liver and other tissue. And so we are looking to see if this might improve things. We know from the group, particularly in Korea, who have a high incidence of viral-driven HCCs, but with high rates of PVTT, that particle beam, particularly protons, may do better even than SABR. So a couple of final slides. We are going to be involved in the NRG US study, which is comparing protons versus photons. So this will be an interesting study, once again, looking at SABR fractionation and seeing if there is a role for PBT and identifying and stratifying patients who are most likely to get a better outcome from protons and potentially treat bigger tumors. And as highlighted by a prior speaker, the role of immunotherapy. And this is a really nice image highlighting how SBRT or SABR specifically has quite a powerful antigen presenting element, which we can then upregulate by adding in checkpoint inhibitors and then achieving that, which is pretty much the unicorn of radiation therapy, the abscopal effect, where we may be able to advance metastatic or systemic control by immunosensitization with SBRT. And we can see that there's some promise with some recent studies coming out, particularly from North America, looking at that. And we will be embarking upon the ratio study, which will be looking at SBRT plus and other radiation therapies, including proton beam, in the metastatic setting with checkpoint inhibitors to see if we can enhance the efficacy of immunotherapy in these patients. So in conclusion, I think there's lack of evidence of superiority of any surgical, non-surgical single modality liver-directed therapy, but I'm not sure that necessarily is a relevant question for patients. Treatments have evolved, and I think our expertise in SABR has evolved as well. And combination therapies may be more effective, but either in sequence or in concert. And research really should be focused on personalization and expanding those non-surgical indications. I've put my email at the bottom, and I'm happy to take any questions offline in the future. And once again, thank you for the opportunity to present today.
Thanks a lot, Dr. Radhakrishna. So our next debater, Dr. Dayananda Lingegowda. Dr. Dayananda sir is an intervention radiologist with vast experience in TARE, TACE, and other ablative technique. And he is currently working in Tata Medical Centre, Kolkata. So he will be speaking against the motion. Over to you, Dayananda sir. Sir, you need to unmute yourself. Dayananda sir, you need to unmute yourself.
Can you see my slides?
Yes, sir.
Okay. Good evening, everyone. At the outset, I thank Dr. Animesh Saha and Dr. Tanmay Mukhopadhyay for giving me this opportunity. Thank you for Dr. Ganesh Radhakrishnan for such a honest presentations, which is very rare to see nowadays. And a couple of years back, actually, we had similar meeting where the topic for debate was where the SBRT was whether equivalent to the local ablative therapies. Now, with 2 years down the line, now there is a lot of aggression. Now, the topic we are discussing is whether the SBRT is superior to the ablative therapy. If someone is saying it's the ablative therapy is superior, also means that it is superior to the surgery, because for a long couple of decades, actually we consider ablative therapy is equivalent to surgery. If somebody is claiming it is superior to the ablative therapy, it also means it's superior to surgery. So I am a very conventional guy. Let us start with a basic principle. The ALARA principle, all of you know about it. If ALARA principle says that if there is a two modalities of investigation, if one modality is a radiation and another modality is non-radiation, is wiser to choose the non-radiation modality as a treatment. So if you consider it is equivalent, actually there is a logic to choose an ablative therapy over the radiation therapy. So whenever there is a problem, actually we look into the guidelines, and this is the BCLC guideline is like a most popular and widely accepted guidelines. So this is a recent update. We cannot scrub it as an old one. So this is a recent update, and here you can see there are few changes have come where now the ablation is actually preferred modality for the very early stage disease. And also previously the TARE, which was actually we are working on more on the BCLCC stage. Now it is upgraded and given, and we can see, so we can use these transarterial radio-embolations in the early stage and intermediate stage HCC. In these treatment options, I don't see any recommendations on SBRT, and NCCN guidelines also like this do include the SBRT in the guidelines, and it says that there is a blanket evidence which is given. It's a 2A. I was a little bit surprised to see a 2A in this category because there are modalities which this is persisting for many decades, and I was a little bit skeptical how come the recent modality which is included as 2A. But when I look into the details, actually which says that actually the 2A for the panel recommends EBRT or SBRT to consider as alternative to ablations or embolization technique when these therapies are failed or contraindicated. That means they are actually already they are considered not as a primary treatment. Only in those cases which are where these ablations is not possible, then only you need to consider for a EBRT. This is for a 2A evidence. And let us see this is Astro guidelines. I just looked into it just to see what is happening in Astro guidelines. There are three strong recommendations in these. Uh, let us see what is these strong recommendations. This one strong recommendation is patients with a liver confined to SCC who are not a candidate for curative options and their own catheter-based therapies being or being not considered, then EBRT are recommended as a potential first line as a single. So that means when these options are not considered, that means it is not equivalent the modality for treatment. Also, another recommendation is the EBRT can be considered when there is a recurrence, incomplete response after thermal and catheter-based therapies. Again, that means that EBRT considered only if these modalities are fails. That means the thermal ablations are given the preference over the EBRT. And another strong recommendation is this patient with locally recurrent SCC after surgery and after thermal ablations. So again, this already they are accepted that the thermal ablation, surgery, and catheter-based therapies are the primary modality for treatment. So let us look into the ESMO guidelines where they have divided into standard care and also alternative treatment. In the standard care, we can see the resection, thermal ablations, and transarterial ablation TACE as in the standard care. With even the TACE is the level 1 evidence with a grade level A recommendations, and we can see the SBRT in the alternative treatment, not in the primary standard of care. So these again the ESMO guidelines. This is the standard treatments which is the resection, ablations, and also TACE, which is a level of evidence. And SBRT is mentioned, but they are given a suffix but it is classified under non-standard alternative treatment should be considered one these modalities, primary modalities, is not possible in subset of cases, not as a primary indication. Again, I looked into China guidelines, which says that actually only this stage 3 onwards only I could see radiotherapy, and again it's similar to the rest of the guidelines. So let us look into the other American guidelines, Europe guidelines. We've already seen Japan and Korean and guidelines. Again, it's almost they are similar, and they've given the standard of care in the initial category is actually resection, ablation, transplant, and only in Korean guidelines there's the radiation is given a place where there is as an alternative treatment or when there is a portal vein involvement. Otherwise, standard of care is still a resection, ablation, and transarterial radio-embolisation. This is a gist of all the world recommendation. If you combine, again, this is as a standard treatment and is alternate treatment. And the first category treatment, I don't find any BRT in the these recommendations. And we are forgetting what is the impact of SBRT radiation on the liver. Actually, this is the paper which says that SBRT has a moderately negative impact on the liver functions, and and this is very, very important when the patients are subjected to the or downstaging, or patient is already cirrhotic. The future, what is the quality of future liver remnant we are going to give? Especially in the ablation and transarterial ablations, generally we don't touch the normal liver. We only try to treat the disease. But it is not the case with the radiations, where there is a normal liver, future liver remnant. What is remaining also, there is not a quality of the quality of future liver remnant is questionable. This is like a liver toxicity which is reported. There are some measurable radiation toxicities, like a total rise in total bilirubin and alkaline phosphatase and cholangitis, and also non-measurable toxicities are also mentioned. And also there is a hepatitis B virus reactivation, which is also mentioned because of immunocompromise. These kind of toxicities are generally not seen with the ablations. These are the ESLA clinical practice guidelines, very good slides. Actually, it's some of all the evidences. Here this row we can see the evidence according to level of evidence: low, moderate, and high. And this horizontal level we see the positive recommendations and negative recommendations. In the positive recommendation and with high recommendations, where we see the chemo-embolisation, radiofrequency ablation, and also along the resection, and the external beam radiation, actually in the fence, it is in between the negative and the positive, and but with a low recommendation. What is this recommendation means? When there is a strong recommendation, which means that the further research is unlikely to change our confidence in these estimated benefit and risk. So there's a strong recommendation for resection, ablations, and TACE. These recommendations comes with not with a small studies. These comes with if you see the studies with analysis, there are 10,000, 20,000 patients. So this is a level of evidence we gathered over the decades. This is an example. Just I want to conclude with this example. This is a lesion. There's a central lesion, which is a large lesion, one dimension. It is measuring 10 centimeter, another 15 centimeter. After one TACE, we are seeing a complete response. There is no confusion in the treatment post-treatment scan, like whether it is a residual disease or there is a complete response. We have I had an opportunity to see a couple of post-radiation liver changes, very, very difficult to interpret in those cases, because there are a lot of confusion and very difficult to report also. And I'm not going into individual studies because the integrity of a small studies are very, very questionable. And if you're good at statistics, these are very, very, very famous book where if you know the statistics, you can screw it up and you can get a desired results. That's what we are very bad at statistics, but still this is a very classic example. If you want to make a Vinod Kambli as a very great player, maybe you can consider only the Ranaji of his scores, and we can make him as a very great player and discard the international scores, telling that they are not matchable. With this, I thank you very much for giving me the opportunity, and leave the over to Dr. Animesh Saha.
Excellent presentation. May I request Dr. Radhakrishna for some rebuttal comments against the talk of Dr. Dayananda? Because 1 minute for rebuttal comments.
Thank you. Thanks very much. I think, as I highlighted at the early stage, we are very much at the early stage of developing our experience and expertise in SABR. I think that is what's reflected in guidelines. So guidelines, like textbooks, often are outdated by the time they are published, but one can't deny the merit in the argument that has been presented. And I think actually going from controversy to consensus, I think we'd agree that there is a role for SBRT, but particularly in a particular cohort of patients as outlined in my presentation. I think the only thing I'd like to suggest is that in this situation, we need more data, and I hope my colleague will agree with me that we need more data and we need more research in this area. And actually, a combined approach may be useful. So I didn't bring any of my good slides to show a response, but one of the things that we sometimes do is where we have patients who have two multifocal HCCs, where we may need to use a thermal ablative technique and SABR technique for a central tumor. And finally, in terms of the issue of RILD and the slide that you presented in terms of the non-classical, classical RILD, and now what we understand, which is central tumors, those are sort of things that we're beginning to understand now and beginning to able to manage. And that's where I think potentially the role of PBT or these liver-sparing treatments with radiation may have a more pronounced role. So thank you. I'm hoping we're on consensus now.
Yeah, Dayanand sir, you got 1 more minute for any rebuttal comments.
There is a lot of scope. I agree. There is SBRT is a lot of scope to play when we work together, and especially when we are looking towards SBRT, especially when there is a portal vein thrombosis that can combine with TARE, combine with TACE in benefit of patients. Maybe it is a combination is the way to go. Synergy is the way to go.
Yeah, very important point. We've got a question in the chat box.
So Animesh, I have a question. This is Ankur Behel, and this question is to Dr. Ganeshan and Dr. Dayananda, if may I ask?
Yeah, go ahead, sir.
Yeah, so Dr. Ganesh and Dr. Dayanand, at times we have multiple lesions, bilobar lesions, and there's a big portal vein sitting on main portal vein, big thrombus, tumor-related thrombus, and the tumor and the case is being discussed in multidisciplinary tumor board. So we know that we need to dissolve this thrombus through SBRT, and for that bilobar lesions, we require a TARE for the best outcomes. So at times, and the patient is still in child PUG-A. So my question is, how do we actually start? It should be an SBRT to the main portal vein, or we should start with a TARE. At times, the patient loses, the caretaker loses the goal, and we land up progression of the disease. So which modality to start with, SBRT first or a TARE first, or a TARE first for a followed by an SBRT to the main portal vein?
The portal vein thrombus is the one which is going to decide the survival. So I would like to start with the SBRT first and see the response. If the SBRT fails to dissolve the portal vein thrombus, maybe should consider the more of a systemic therapy rather than going for a TARE, because the portal vein thrombus is the one. Either we have to address this with the SBRT, or we should address with, if we are able to cannulate if it is very vascular, sometimes we are able to cannulate that feeders and we can embolize. That is also another option. But we should address the portal vein thrombus first. That is a gist.
Okay, and in your experience, what is the success rate that SBRT dissolves that portal vein thrombus and improves the child PUG or improves the liver functions?
So I've not seen many cases of SBRT in our hospital. Mostly we only a couple of cases have, so I'm not difficult to say with my experience alone. But I've seen in other centers they are getting very good results when they're for a portal vein thrombus per se.
Dr. Ganesh, any experience with SBRT to portal vein thrombus?
Yeah, so but not in this context. So I think in the UK, a patient with multifocal disease with that extent of disease would go down the systemic therapy route. So they'll probably be getting atezo-bev if they're child's PUG, and then we may sequence treatment depending on their response after that. I think the interesting data here will be, particularly the role of particle therapy and PPT, because you're sparing a lot more liver, and then if you're then going in to give another liver-directed therapy, as highlighted by my colleague earlier, it may spare a lot more of the risk of background liver damage. So I think the short answer is I don't know, but often in the UK anyway, we'd probably be more inclined to treat that with systemic therapy.
So Dr. Ganesh, one question that if given a chance, would you like to radiate the portal vein and the liver lesion together, or you will give a gap between them? Because we have seen that post SBRT, there's a couple of lots of hepatitis which happens and it deteriorates the liver function, and we are not able to give our systemic therapy, atezo-bev or even lenvatinib, sorafenib with
Correct.
that extent.
Yeah. So I think that the tricky issue there is, you need to speak to radiation oncologist, the clinical oncologist, and they need to look at the scans with you to sort of work out what is and what isn't possible, because it's about getting the dose in and knowing how much you're going to spare. So I think, it will be a case by case basis. But in my personal view, I think as much as possible for the ones that we've treated, we treat the tumor thrombus and the primary at the same goal.
Okay.
I think
you so
Dr.
much.
Hingrani want to make a comment. Can we allow Dr. Hingrani to make a comment? Dr. Mohan Hingrani has raised hand.
Yeah, I think thanks. Yeah, I won't take long, but that was an excellent presentation, both I think Ganesh and Dr. Dayananda. I think I work in a center in the UK where I don't have SBRT for liver lesions, but particularly for HCC. So we do SBRT for liver metastases, but not liver actually for node and bone. So we have a problem. So when we have HCC in our clinic, in our NDT, which is not suitable for surgery, we probably go for either RFA or TACE options. So my question to Ganesh was that, can you give me a specific example where you would think that the patient does need a referral for SBRT? Because I guess the evidence is that they're all probably equivalent as of now, but is there any specific example where you think I should probably be trying to push for SBRT?
So I think, the ones that we discuss it through our MDT are the bigger tumors, the central tumors are the ones that are segment 8, segment 7, where, you've got the lung interface there, where we'll access that and we won't need to compromise anything in terms of getting the dose in. So those are the ones that preferentially at the moment, my colleagues in hepatology and interventional radiology kind of let me have, if that makes sense. But the other option, Mohan, is just to go in for one of the standard ablative techniques, so TACE, TARE, or potentially RFA, MWA, and then come back and treat that with SABR afterwards. So,
yeah, and you're the leading expert on protons there at Christie anyway. So have you been using protons? Not as yet for treatment?
We're not allowed at the moment. NHS England is not signed us off. So we will launch with NRG. So when NRG comes online, hopefully in the next few months, the UK will have access to proton beam therapy.
Okay, that's great.
I think we are running short of time. We have to conclude our session here.
Thank you.
So thank you, Dr. Ganesh Radhakrishna. Thank you, Dr. Dayanand sir.